All right, this is Chapter 18, Measuring Vital Signs. Again, the disclosure, I don't own this material. Under fair use, I'm providing lecture content for only my nursing students using this material. All content within is only for educational purposes for nursing students and does not provide or warrant medical advice. So I wanted to give you some helpful hints on how to figure out vital signs before next Tuesday when you're going to be doing them in the lab, learning about them in the lab, and getting checked off before week 6 on these. So blood pressures especially can be a difficult thing to master in the beginning because you don't know what you're listening for. So I am giving you 3 places to go for extra help for these things. There's 1, practical clinical skills, taking blood pressure. There's ATI skills in your ATI modules that will help you. And then the foryourcna.com has skill videos of actual CNAs and people doing these skills in real life, so that if you've never seen this being done, you can have a video for that. So the taking practice one, you can see on this website. You go down here and click on this picture, and the sphygmomanometer will be there. It has 8 patients in here. And when you click the video play button, it will give you the reading. You have to listen for it and then put in your reading, and it'll tell you if you're right or wrong. So that's a good website. And then the other one, are you ready for your CNA exam? Watch the videos, pass the test kind of thing. So there are tons of different videos in here. Hand washing, measuring and recording a pulse, respirations, passive range of motion, gait and wheelchair, gait belt, range of motion, dressing a patient, mouth care with dentures, feeding a patient sitting in a chair. There are just tons of videos in here, including catheter care and emptying the bag, things that a CNA would do. So it helps you get on your way if you've never been in a hospital or never done any CNA care. If you have, we're going to bring it to the next level, because CNAs are good for collecting data, but then once you have the data, what do you do with it is the next part. So that's our goal this quarter, is to provide you more information to get you from the CNA level of doing tasks to actually understanding what those numbers mean. All right, let's get started. Vital signs are a means of assessing vital and critical physiologic functions. Variations reflect a person's state of health or functional ability of the body systems, so it tells us when something's out of whack. The importance of accurate assessments, the interpretation of those numbers, and the documentation of vital signs cannot be overemphasized. Almost everything we do comes back to the data that was collected. Garbage in, garbage out. You don't actually take the vital signs and you just make up a number. You may miss the signs and symptoms of a decompensation patient. So you want to be very careful about that as well. You can get caught for falsifying documented records. So you can lose your license for falsification of records, which would be, I don't want to go take that set of vitals. They've been fine all night. Okay. Falsification is also kind of in the way of putting in somebody else's vitals in a different patient chart. That would be falsification if you did it knowingly. If you didn't, then you go in, make a record error notation, and note the right vitals. That happens all the time if you're not being careful. So make sure you have the right patient's chart open before you start documenting vitals. Vitals, I will tell you also in the hospital setting, they do go places. So there are computerized systems of Muse score, Pew's score, So pediatric or medical advanced warning signs are based on vital signs. So garbage in, garbage out. If you have a bunch of people running into your room from the ICU, it probably means that there was a MUSE or a sepsis alert sent to the charge nurse in the ICU, and she is told to come up and see what's going on with that patient because it looks like they're decompensating with their vital signs that you just charted. So that's why we can't overemphasize the importance of documentation that's done correctly. So vital signs are performed on a regular basis. They are frequently determined by provider order, nursing judgment, patient's conditions, and facility standards. You can always do more vital signs, but you cannot do less based on a doctor's provider's order. Judgment, when you get to court, they will ask you if you knew that they were decompensating, why didn't you take more frequent vital signs? The most frequent vital signs that we usually do are every 5 minutes because that gives you time for the medications to go in, make an effect, and come back. So the most frequent vital signs are Q5, Q15, Q30, Q1, Q2, Q4, whatever. So based on the facility's protocol. Now, if it's a post-op patient, that's usually standard routine across the nation, across nursing, is that you do 15 times 4 for the first hour, 30 times 2 for the second hour, Q1 for the next hour, and at that point, then they're stable and they can go from PACU to the floor or whatever. So just a concept that there are different vital signs for different reasons, and if somebody's post-procedure or post-surgical, there will be standard facility-wide policies on that. Sometimes it's Q week in a nursing home, okay? So everybody has their own. Obviously, if ever you're giving a medication and there's standard routine orders for don't give or hold if less than 60, you would make sure that you go do that right before you give that medication. All right, so vital signs typically in a hospital are every 4 or 8 hours. Sometimes they can be Q12. Most of the time in a stable patient, they're going to be Q4, which means 3 sets in a 12-hour period. Home health setting is usually with every visit, a clinic each visit, and then nursing homes, like I said, are weekly or even potentially monthly if there's no risk factors. At the end of life, they might actually say no more vital signs because what's the difference? If you're comfort care, you're comfort care. Okay. So temperature. Why are we taking somebody's temperature? To see the degree of heat maintained by the body, to see the difference between heat produced by the body and heat lost to the environment. So temperature tells us a lot. It tells us if they're cold stressed or heat stressed or sick with a fever, infectious processes. So that's why we're looking at temperature. Traditionally, the normal body temperature is 98.6 or 37 Celsius. But recently, research showed that a mean body temperature of 97.9 is within range. So we're not really worried about 97.9. You will hear that again in pediatrics and babies because we don't care unless it's under 97.9. If it's less than 97.9, then we have to take the baby to the warmer and warm them up because they're not stable. And then typically, you will see this range of 99.8. Typically, like in moms, we tell them no more than 100.4 for baby or mom. So you'll see different ranges. Just know that on the NCLEX, they're going to give you like 94, or they're going to give you 96, or they're going to give you 103, okay? Typically, they're going to show you that it's way out of range. The only issue with that is there are some people that have trouble, like immunocompromised. If you're immunocompromised, you have cancer, an immunosystem problem, then you would want to know if there's a low-grade temp, because a low-grade temp is your warning that they might be going septic or there might be something brewing. So on the test question or the NCLEX question, if it's like an HIV patient, somebody immunocompromised, cancer, lupus, things like that, you would want to make sure that you report that slight temperature. Otherwise, it's not high enough to treat it with ibuprofen or Tylenol until it reaches 101. It's also found that older adults have lower body temperature and noted variations in temperature based on gender. So surface temperature is usually lower than the core temperature. So we use oral or axillary methods. Oral on adults, oral on children up to a certain point. Otherwise, you may have to use axillary. Axillary being under the arm. So you're putting it under the underarm. This can be helpful if they just took a drink of water or just drank some coffee. You can always put it under axillary. Otherwise, you would wait 2 minutes and then come back and take the temperature again. Axillary under the arm for every baby. So thermoregulation is a concept that you need to remember, especially when you come back to this in babies. It's the process of maintaining a stable temperature. Constant body temperature balance between heat loss and heat production, and that is controlled by the hypothalamus. So if somebody is at the end of life, had a stroke, there's damage to the hypothalamus, they will get very, very hot, and you will have to put them on a cooling blanket. So that's a basic regulation that you don't think about. So the production of body heat, if you think about it, it's metabolism, burning calories for energy to maintain your body temperature. Skeletal muscle movement would increase body heat. So someone who just did a triathlon, there's a lot of body heat there. And then non-shivering thermogenesis, this will come back to haunt you again in OB, because babies do not shiver. Babies don't have that ability to warm up with skeletal muscle movement like shivering. So they end up using up the brown fat on the back of their shoulder blades. That's why a premature baby is in an isolette, because they don't have those storages on the back of their back. So they would burn through that very quickly and have a low glucose because they're trying to burn their fat to keep warm. So that's why we put them in little isolettes. A normal newborn probably would be okay as long as we have the kid covered. We don't have them under a vent in the room. As long as the AC is not running, that kid will be just fine. But a premature baby would not be able to handle that because they don't have enough fat stored. All right, so there's some ways that we lose heat. Again, this will come back to haunt you in OB, because when a baby comes out, it's all cold, it's wet, it's slimy. Think about that. How do they lose heat? So there's 4 main ways: radiation, conduction, convection, evaporation. So radiation is a loss of heat through electromagnetic waves emitted through surfaces that are warmer than the surrounding air. So you get heat or you lose heat based on that. So what we consider conduction, in a minute you'll see that. Radiation is like if the AC. So convection, again, transfer of heat through currents of air or water. So again, if it's really hot outside, people are going to get heat stroke because of that heat through currents of air or water. Evaporation is loss of heat, loss of vapor through the skin, like perspiration and mucous membranes through breath, but also like being on a crib or an open crib with an air vent right over the crib. So being careful with that, especially in the nursery. If there's a lot of air coming through the windows or a lot of air coming through the vents, you want to move that baby out of that area. In Montana, it was so bad in the NICU that the outer windows would actually freeze in the winter. So we'd have to make sure we don't have babies in those rooms when it was 30 below, because the room would be much, much colder and could not stay warm. And then conduction is the transfer of heat through a warm to a cooled surface by direct contact. So again, putting an ice pack on. Okay, the ice pack's colder than you, so it helps conduct that cooling sensation through. This is the same thing in babies if you don't put a blanket down before you put them on the scale. Scales are usually hard plastic, cold metal. So anytime you think about putting somebody on a surface, it should be a warm surface, not a cold surface, or else you're making them lose heat. So that's why we put them on radiant warmers that have been on for a little bit before we put the baby on it. All right, so factors that influence body temperature: the developmental level, the environment, gender, exercise, emotion, stress, circadian rhythm. So you know during the day your body temperature is higher, during the night your body temperature is lower. So remember circadian rhythms. So what is an unexpected? So unexpected fever, also known as pyrexia, pyrotechnic, fire, fever, fireworks, right? So pyrexia, fever, over 100. So typically we also say 100.4. So you'll see different numbers. Again, where are we worried about it? If we're worried about it, is it expected? So if there's a bacterial infection, it occurs in response to pyrogens, like bacteria. Okay? If I have pneumonia, it would probably not be unexpected that I have a low grade temperature. Would I want 104? No. So the little bugs secrete substances that reset the hypothalamic to a higher temperature, allowing the body to get hot. And then abnormally high, a fever greater than 105.8. So in kids, we talk about febrile seizures because the kid gets so hot. Okay, so that's the biggest thing that we're worried about when somebody has 105.8 temperature, is that they're going to have seizures. So you're visiting an older patient with the home health nurse. The temperature for the past week have been over 92 Fahrenheit with a heat index of over 100. The first patient is a frail 84-year-old who lives alone on the third floor of a building without air conditioning. What measures would you take to promote safe, effective nursing care using the thinking, doing, caring model? So think about this. Heat rises. He's living alone without air conditioning. Think about some things that you would suggest. The fact that he's a frail 84-year-old, those kind of people are already at risk for dehydration to begin with. Right? So drink, different cool liquids. The only problem with that is thinking, if he's CHF, I don't want him drinking that much. If he has renal failure, right, within measure. So you're thinking about everything possible that could happen. Could he move to a lower level? Does somebody else in the family have air conditioning? Is there somewhere that they can go? This is the question. Also, worst case scenario, they refuse all measures, at least know that they have a phone and they can call 911. Someone to check in on them. So discuss what you would think. So we would give you time to do that. So then variances in temperature on the other side is less than 95 degrees. It's associated with extended exposure to cold, extreme weather, immersion in cold water, and lack of shelter or clothing. So in the northern regions, sometimes we have immersion in cold water when people go ice fishing and they fall through the water. So there will be questions on the NCLEX about a couple of these different things. When you see this one, it's going to be someone that's been immersed in cold water. Consider cold damage. What would we do for those tissues? We would warm them up slowly in warm water, not hot. Don't massage the tissue, it'll slough, right? In the old days, they used to say get a sleeping bag or a blanket and put two warm people next to the cold person for the radiation and the conduction of that heat from the other two people into the cold person. So when you are talking about like natural medicine in the middle of nowhere, things that the military does, think about those kind of things. What would you do if there's a lack of shelter and clothing and it's cold? That's the homeless. So what do we do for the homeless? Get them shelter, get them warmth, make them blankets, right? Things that we can do. Give them warm clothing. What did you do last week when it was cold? Y'all ran to Walmart and got some sweats. Put an extra layer on. So when you're hypothermic, add clothing. When you're hyperthermic, take clothing off. So the course of a fever, typically what happens is initially the temperature rises, then it runs its course, and then third, there's a crisis if it continues too long, okay? So febrile episode, do you run and take Tylenol? No. A lot of times they will tell you do not go run and take Tylenol if you have a fever because it's running its course. Your body is doing exactly what it was supposed to do. So when people got the COVID shot, they told people do not take Tylenol. It's doing what it wasn't intended to do. So a lot of people think in the thought process of leave it alone, let it run its course. If it gets too much, yes. And if it's leading to a crisis, yes, give Tylenol. But there is a school of thought that it's okay. The other school of thought is after the Tylenol is doing blood cultures, seeing what bug it is and which antibiotic would be effective, if it is effective. If it's not a viral thing, antibiotics aren't going to help that. So there are different things that we can think about, but if we're going towards sepsis, because it's a bacteria, we need to kill the bacteria. So, little quick check. The nurse would monitor body temperature most closely, frequently in the care of A, a patient with an infection, B, a patient who's an infant, C, who has experienced heat stroke, or D, with a head injury. Which patient would you monitor more closely or frequently? Expected, unexpected. Who's going to die first? This is the trick that you use on these kind of questions. So, what is the information telling you? What is the information telling you is the question. So, all of the patients would need to have their temperatures monitored closely. However, the one with the head injury may have damage to the hypothalamus, therefore cannot globally thermoregulate. So the temperature of that patient would need to be monitored more frequently. So you see how they tried to trick you. With an infection, the temperature is expected. An infant, because of surface area, who has experienced a heat stroke, expected to have a high temperature. But a head injury, the head injury is the most unstable of these patients. Everybody needs their temperature monitored, but I might not monitor it as closely as a head injury patient. Where does temperature come from? The hypothalamus. Okay, so any damage to that thermal regulation center would be more important than the others. Not that they're not important, it's just which one is more important. So when you get a neuro patient, somebody with a head injury, you're doing temperatures quite frequently. All right, so temperature, follow the measurement scale of the facility. So again, depending on where you are in the US, Canada, Mexico, Australia, wherever. So we don't want to just teach to the US because some people may be in the US and be close to Canada or close to Mexico where that facility and those doctors have decided that Celsius is more important. Most computer systems will change from one system to the other very quickly, and whether you put it in Celsius or Fahrenheit, both will be monitored and recorded, so that you don't have to worry about that. But using the equipment approved by the facility, so again, if your equipment's not working, putting in a work order, because you cannot just bring your own thermometer to work. All medical equipment that's used on patients that are being used to make a treatment decision have to be monitored by the facility. You can't just bring your own thermometer. Just like you really shouldn't bring your own blood pressure cuff because they have not been checked by the facility and maintained record of maintenance. So that's a whole nother lecture on someday. But equipment must be approved, trained, and maintained by the facility. Choose the safest, most accurate, and most reliable site. So what site would you use? The safest would not be rectal, because rectal thermometers tend to puncture through. We don't want that. Most accurate, usually oral. But if they just drink something hot or cold, that would not be reliable. Come back, retake it. All right, so pulses. Pulses come from the rhythmic expansion of the artery produced when a bolus of oxygenated blood is forced into it by the contraction of the heart. So pulses, we are measuring a pulse rate for a minute. So again, if you're a CNA and you've already learned some bad lessons out there, every patient that you meet for the first time, you will take for a full minute Resper's pulse, okay? Why do we do this? If you think about it, there are murmurs that we would not maybe catch if we only did 15 seconds, if we only did 10 seconds. There are a lot of old people with heart irregularities that we would not catch if we only did 10 seconds. So please be sure you're doing a full minute. We will check you on that in the lab as well. Think about this, especially in kids. Kids' pulses are really irregular, especially babies. So you definitely want to make sure you average it over a full minute. So a normal pulse rate for an adult, 60 to 100. 100 not unheard of, but the average is somewhere between 70 to 80. Am I going to get concerned with 60? No. Am I going to get concerned with 100? No. Read the question. What have they been doing? If they just ran a mile, if they just went around the unit and they are not in good shape, don't you think their heart rate's going to be up? If they are sleeping soundly with a sleeping pill on board, is 60 abnormal? Okay, so really look at your situation when you get to a test question. If it said 40, Yes, absolutely. If it said 220, yes, absolutely. You'll learn what to do about those later. Okay? But the pulse is the wave that begins with the left ventricle when it contracts and ends when the ventricle relaxes. Each contraction forces blood into the already filled aorta, causing increased pressure in the arterial system. The systole is the peak of the wave, or the contraction in the heart, and the diastole, sys is full, diastole is trough or resting phase. So that's why systole is the high number, the top number, because it's the peak of the flow of blood, and diastole is the last beat you hear. So when you're taking blood pressure, you're listening to the first beat and the last beat. That's why systole and diastole, that's where those come from. So when you're feeling a pulse, you're feeling that wave. So taking a pulse in different places tell you different things. Stroke volume, the quantity of blood pumped out with each contraction of the left ventricle. We'll talk about that later when you get into cardiac in your last quarter, one of your last quarters, quarter 9, I think. So just think about that. Cardiac output is your stroke volume plus your heart rate, or times your heart rate. So that's how much you're actually putting out, the volume of blood and the heart rate. And then your ANS, your autonomic nervous system, you will see that regulates your heart rate. So it's not something we have to think about. It's autonomic, it's automatic. So we don't even have to think about it. That's something that's controlled by our brain. So factors that influence pulse rate: developmental level, gender, exercise, food intake, caffeine, stress, caffeine, fever, high heart rate, high pulse rate, right? High heart rate, high fever, my blood starts pumping faster. Disease, mostly vein disease. Blood loss, if I don't have as much blood in my system, it's not going to pulse very well. Position changes, you will get this soon. In med-surg, you will start learning about orthostatic hypertension. Hypotension, orthostatic means when I stand up, my blood pressure drops. So does my pulse. That's a big problem if you're taking medication that drops your pulse as well. So medications can increase or decrease the pulse rate. We will talk about a whole bunch of drugs called the LOLs, which are LOL, everything ends in LOL, like metoprolol, labetalol. Those are medications that are meant to decrease the pulse rate. So would you want to give them if they're less than 60? No, you would hold that medication, and you have a doctor's order to do so. Why would you want to give medication that's going to lower the rate already? They're going to be on the floor. They're going to fall. Obtaining a pulse rate. Apical is most accurate and also the most easiest to get, but you do have to ask permission. Apical is at the apex of the heart. So when you're looking at someone, it's straight down about an inch or two from their nipple, straight down. That's where the maximal point of impact is on your heart. You use a watch or a clock that has a second hand, or a digital display. So a second hand, which means the third little hand that goes around the clock, or the seconds on your digital watch. And then the heartbeat is a series of a lub and a dub, a lub and a dub, lub dub 1, lub dub 2, lub dub 3. So when you're doing a pulse rate, so some of the other places that you'll see someone do a pulse radially, radial is on the lateral aspect of the anterior wrist. You never use your thumb, you always use your 2 fingers. If you draw down from your thumb straight down, you will go straight into the groove automatically. Can you feel your radial pulse? Brachial artery. Brachial artery is halfway between your elbow and your shoulder in the inner aspect of your arm. This is where we go for a child because their little neck is fat and rubbery and we can't get in there. So the easiest place usually on a patient is brachially. Carotid is on the side of the neck. So if you go down from your temporal by your ear, past your eye, by your eye, down past your ear, into the groove, you should be able to feel your carotid. Only trained professionals for CPR and assessing circulation to the head. This is the only time you should take that one because you could occlude the carotid. Okay. People that have a lot of fat plaques in their neck, you don't really want to occlude that. So only by trained professionals because you could miss it very easily. That is not an easy one to get into the habit of doing. You don't want to be touching the wrong place, not having a pulse, and call them dead when they're not. Temporal is on the side of your forehead, in case you ever see that pulsing when you're stressed or anxious. Dorsal pedis, dorsal top of the foot, pedis. Okay. Femoral in the groin fold. So a lot of times you'll see, like after a cardiac cath, a sandbag in their crotch. Why is that? We're putting pressure on the femoral artery because it may spurt. So femoral, usually the dirtiest place to put a central line. Anytime anything is femoral, just expect it to be dirty, right? Yeast infection, fold, a wet fold, full of yeast, okay? So that's usually the worst place to put a central line or an IV, but it is one that we need to use for like ICU, cardiac cath stuff, because it's a great big artery to be able to get into. Popliteal behind the knee, and apical is the apex of the heart. So you need to know where to find those. You need to know those names because they will ask you about different sites being more or less appropriate. So if somebody has a broken foot, where are we going to touch? Think about it. You always want to do CMS, color, motion, sensitivity. Color, motion, sensitivity, pulse. So if somebody has a broken foot, I might use the dorsal pedis if my patient doesn't have a cast on. I can't do behind their ankle because of the cast, so I would have to go popliteal. So I always go distal to proximal, distal being furthest away. So I would try on his toes, on his foot, on his behind his knee would be probably the last one before I go to femoral. Okay? Different pulses, different places, you gotta know them. When do you measure an apical pulse? When the radial pulse is weak or irregular. What do? What we do is put one set of fingers on the radial, and we also have our stethoscope on the heart. So we're doing both at the same time. That's when we're checking to make sure that they're both equal, because if they're not, we're in trouble. Adult or infant, we're in trouble, because there's a mismatch of the heartbeats. If one's 60 and one's 100, we're in trouble. They should be pulsing at the same time. So the rate is less than 60 or greater than 100. The patient is taking cardiac meds. Are the patients an infant or a child up to age 3? Because peripheral pulses might be difficult to palpate. So how do you find that apical heart rate? Okay, so basically what I said was usually the nipple is right here, okay, on an adult. So think about this, your age is going to make a difference, right? So typically right under that nipple line, if you notice that little circle right there is a nipple, you're going right below it on this side of the heart. If you look at the heart there, that's the point of maximal impulse, which is closest to the skin. How do you get it even closer? So technically, you would have them lean forward and the heart would come towards you if you could not hear it. Okay? All right, we'll talk about these different heart sounds, especially in assessment, right? But there are other heart sounds that you're listening to as well. Okay, pulse deficit. You hear a heartbeat, but you don't feel a pulse at a pulse point. That's a pulse deficit. I cannot feel a pulse. That's different than they don't have a pulse. Bradycardia less than 60, tachycardia more than 100. So tachy, too high, brady, too low. What is the regular rate? Is it regular or regular? So when you're hearing it, it should go lub dub, lub dub, lub dub, lub dub, lub dub. If it goes lub dub dub, lub dub dub, we're in trouble. That's a murmur. Something's wrong. It's a split second sound or a third sound. Okay, so you listen to regular rhythm, irregular rhythm. Is it going lub dub, lub dub, lub dub? There's a huge pulse there, a huge deficit in between two pulses. That could be a murmur. You're also listening to the quality of the pulse. So when you feel the quality of the pulse, is it thready? Is it really weak? Or is it really strong? Bounding? A bounding pulse would be an indication of fluid overload. A thready pulse, a weak pulse would be dehydration. So this is what you're thinking when you're doing this. It's more than a number. It's more than making up a number. It really tells us a lot of information. You've got to be specific on these things. Inadequate circulation. How would we know? Blue or pale skin? Anytime you see blue or pale skin, we're in trouble. There's either circulation compromise, blood flow compromise, excessive carbon dioxide, not enough oxygen. Something is wrong when you see blue hands and feet, blue legs, okay? At the end of life, you'll start seeing cyanosis. Okay, this will come back to haunt you in maternity when it talks about acrocyanosis. Acrocyanosis is normal in the first 24 hours of a baby's life, that their hands and feet are blue because their body, the trunk, is more important. So it takes them time from going from their circulation, their mom's circulation, to their circulation, and it takes them about 24 hours to shut all the valves in their heart and the shunts in their heart that are open because they are getting mom's blood and oxygen first in life. Pallor means paleness. If you think about pale, it could be compromised circulation, so you may not be able to feel a pulse. So you're looking for paleness of skin. If it's cold and pale, there may be a compromise of the blood flow down to that extremity. Super important. So some of the nursing diagnoses associated with this would be peripheral tissue perfusion alteration. That's blue hands and feet or pale skin. Risk for impaired skin integrity. If there's no blood flow getting to that skin, how can it be healthy? Risk for impaired tissue integrity. If I sit on my butt for more than 24 to 48 hours in a row without changing positions, there's not good blood flow. There's a good risk for a wound to happen. Deficient fluid volume, excess fluid volume, decreased cardiac output. Again, these are all nursing diagnoses. So instead of seeing dehydration or fluid overload, those are physician words. These are nursing words. So again, there are outcomes and interventions like vital signs, dysrhythmia management, vital sign monitoring. These are outcomes, stable vital signs, vital sign monitoring every 2 hours, every 4 hours. Okay, so pulse check. The nurse is assessing a dorsal pedis pulse in an 88-year-old patient. Where did we say that was? They note the patient's feet cold, cool, and assess weak, thready pulses. What should the nurse do next? I will give you a clue. What do you think you should do first? What do you think you should do first if you have feet cool and weak, thready pulses in their feet? Do I assess the popliteal and femoral pulse? Do I assess a 1-minute apical pulse? Do I notify the provider, or do I apply a warm pack and reassess in 20 minutes? Herein lies how to answer these questions. You're probably not notifying the provider stat because, remember in my other video, when you assess first, then diagnose, then plan, then intervene. Intervene would be D. A warm pack would be an intervention, so I don't want to do that. Assess an apical pulse. Well, that's a long ways away from their feet. So A would be more appropriate. I want to do a full assessment. Whenever this says, what should the nurse do first? What is a nursing priority action? It's never going to be call the doctor first. What is the doctor going to do? He's going to ask you, well, did you feel all his other pulses? Think to yourself, I should do a full assessment. Okay? Now, if you were a CNA, yes, you run and get the nurse. You're no longer a CNA. Guess what? You're in a BSN program. You're the boss. Everybody's coming to you. They've already assessed. They're coming to you because they're freaked out. What are you going to do? Ask them if they assess the other pulses and go find out before you call the provider. You don't want to look like an idiot in front of the provider. The provider is going to ask you for more documentation, more assessment. So assess the next highest pulse. I would go to the popliteal, then I would go to the femoral. That tells me if there's blood going down the leg, or if it's a problem on the foot, a problem behind the knee, or a problem in the groin. Tells me how bad the problem is. If I have a full pulse popliteal, then I know it's a problem in the lower leg. Okay? Then I call the provider. Okay? So complete a full assessment. Add pi. Assess. All right, moving on to respiration. Respiration is respiratory. So it's both a mechanical and a chemical process. So there's chemical process of oxygen and carbon dioxide going on. There's also a mechanical process of actually breathing and breathing tissue, right? So the exchange of oxygen and carbon dioxide in the body. Breath in, breath out. Mechanical. Mechanical respiration, whenever they say that, that's pulmonary ventilation. The fact of breathing. Whether that's artificial or not is the question. Artificial mechanical ventilation is a machine doing it for me. So a ventilator. Whether it's ventilation or not, there's an active breathing, the active movement of air in and out of the respiratory system. Chemically, you're seeing an exchange of oxygen and carbon dioxide, the transport of oxygen and carbon dioxide throughout the body, an exchange of gas between the capillaries and the tissues, down at the very toes, down at the very tips of the fingers, right? So that's why we look for capillary refill. That's why your pulse ox won't work very well when you have blue hands and toes and cold hands and toes. So you're looking at rate and regulation. Rate is going to depend on age, exertion, emotions, and factors. So this will come back to haunt you in OB again, because different age kids have different age related rates of respiration. What's normal for a newborn is not normal for an adult. Smaller body, smaller lungs, they need to breathe more often. So what's normal for an adult, 30 to 60 respirators a minute, would not be normal, but that's okay for a kid, especially a newborn in the first year of life. So regulation of respiration comes from the level of carbon dioxide in the blood. Chemically, there's chemoreceptors, and peripherally, there's chemoreceptors that tell the body increase respirations or decrease respirations based on the level of carbon dioxide in the blood. Inspiration draws air into the lungs. Inspiratory, expiratory. Inspiratory, breathe in, breathe out. So breathing in involves the ribs and diaphragm and creates a negative pressure, allowing airflow into the lungs. Think about this. Someone with a broken rib is not going to want to inspire deeply because it's going to hurt. Expiration. Asthma, they can't get the air out because the air is trapped in their lungs, not being able to come out. So expiration is relaxation of thoracic muscles and the diaphragm, causing the air to expel from the lungs. It's passive and usually takes 2 to 3 seconds. All right, so again, look at the diaphragm. During inspiration, the diaphragm is contracting. During expiration, the diaphragm relaxes. So look at your chest when you're breathing. Your chest should be rising and your diaphragm contracting. And the opposite is true. Okay, so get use of watching this, because visual assessment's really key when you have a flail chest, gunshot wound, or blown lung. Being able to observe these lung fields equally rising is important later on. See this big hole? That's for the heart. There are several lobes, so look at the lobes. Okay, it's not just one tissue. There is one bronchiole coming down, trachea coming down, bronchioles, one to the right, one to the left. All right. So, factors that influence respiration. Again, same things. Some smoking there, some stress and pain. Think about this. Anxiety, hyperventilation, pain, hyperventilation. Medicine can also influence respiration. We're going to talk about that quite a bit in med-surg. When you put somebody on a PCA, a patient-controlled analgesic called morphine, opioids can cause your respirations to slow down or cease, worst case scenario. Your hemoglobin is oxygen carrying capacity of the blood. So the more anemic you are, the more you breathe, trying to get oxygen to the blood. Okay, Counting respiratory rate, you should count again for a full minute. It really doesn't matter when you do it, right? Technically. But you should count the respiratory rate after taking the radial pulse. If you do the respiratory rate first, they might be thinking that's what you're doing first. So they'll start altering their pattern of respirations when they think that you're watching. So typically what you do is put your hand on their pulse and count the respers, and then count their pulse. It'll change, right? You might want to do a minute of one and then a minute of the other. But don't tell them what you're doing, right? I'm watching your chest rise, because then the patient can alter that. Okay. Respiratory rate must be accurate, especially in older adults, especially people that are on pain meds, because respiratory rate makes a big difference what you're going to do. If it's under 12, we're concerned. If it's under 8, we're going to intubate. So that's a problem, right? So it tells you what you're going to do. If it's 12, you're going to hit them, make them wake up. You want them to wake up. You want to say, hey, dude, what you doing? Wake up. Take a breath. If it's under 8, they're probably not going to respond to that. And you're going to have to go ask somebody about the policy for doing Narcan, narcotic reversal. Okay. So these things you'll learn in med surg. I'm just giving you a prelude to it, that respiratory rate is really needs to be accurate, because it really changes what we do for them. So apnea is a cessation of breathing, especially at the end of life. Bradycypnea, apnea means oxygen. So breathing that's too slow, Brady. Breathing that's too fast, tipky. And then you're looking at the depth. Is it shallow, deep, normal? What's going on there? This is going to be very important with your diabetics. Okay? It's going to come back to haunt you if you don't think about it now. Get your assessment down now. So rhythm. Talk about some abnormal rhythms of breathing. Cheyne-Stokes. Cheyne-Stokes is an abnormal breathing pattern at the end of life where they almost hold their breath and have periods of apnea where they're not breathing at all. And that's normal in the end of life, but not normal normally. You would not want to see that if somebody was not on a hospice end of care. Okay. Cheyne-Stokes is not good. Biots, look that up as well. You gotta know these. Okay. Biots is kind of like a seesaw-like appearance. Okay. So what you're looking for is the effort, the work of breathing. So think about this. Dyspnea. Dyspnea. Anything is dysfunctional breathing, labored breathing. Why would somebody be labored breathing? Pneumonia, asthma, COPD, emphysema, right? There's lots of reasons why. When you know that they're labored, that's an indication they need some oxygen. You might want to put an O2 sat monitor on and see what their O2 saturation is. Dyspnea is telling you there's a problem. Orthopnea. Okay, we talked about orthostatic hypotension, being standing up. So think about this. This is the inability to breathe when lying horizontal. What's the first thing you do when somebody's having trouble breathing? Put their head of their bed up. Not being able to breathe when they're horizontal. This is the old guys with COPD or emphysema that tell you they sleep up in their chair at night. They're not able to breathe horizontally. Imagine that patient going to the OR. They're going to be flat coming back out of the OR, right? We can't do surgery on a patient sitting up. This is going to make things difficult for the OR team. These are things we need to know before we go. All right, so pulse check. The nurse will expect to find a slower respiratory rate in the patient who has smoked for many years. Slower respiratory rate? Higher respiratory rate. What do you think? Think about the function of smoking. What does smoking do to the tissue in the lung? What do you think that's going to look like? Emphysema? Do they breathe slower or more fast? What are their volume, their capacity of oxygen? Thought process. Look at the physiology behind it. Remember A&P? You loved that class. Comes back to haunt you if you didn't do the work then. So you might as well learn it now, right? All right, so increased respiratory rate to compensate for the loss of elasticity in the airways. So similar to emphysema, COPD, chronic pulmonary, loss of elasticity, so they have to breathe faster to get as much oxygen in. They can't take deep, deep breaths. All right. So breath sounds, when we talk about breath sounds, I'll give you the caveat that if you own a Littmann stethoscope, or even if you don't, you can go on their website, on your app, on the phone, and there's a little L, that's a blue website, and you can download a free 1 year if you don't have this stethoscope. If you have a Littmann stethoscope, you can actually download a module that gives you breath sounds and lung sounds. So a wheeze, these you have to know. You have to be able to recognize them on the NCLEX. They will have a sound bite, and you will have to say, what would you do? You may even have to identify the sound. So now is the time to get it done. Wheeze, high-pitched, continuous musical sound heard on expiration. Who wheezes? Asthma. Can't get the air out. Wheeze. Rhonchi is a low-pitched, continuous sound caused by secretions. So the last time that you were sick, you were probably like, you can hear it, it's secretions. This you can hear high-pitched is air, usually, getting caught through a restricted airway. Bronchi is secretions in the large airway. Crackles is discontinuous sounds usually heard on inspiration, maybe high-pitched popping sounds or low-pitched bubbling sounds. Sounds like snap, crackle, pop. Crackles. Popping sounds. Find a really good website and learn those really good. Stridor. Anytime you hear stridor, that's a problem. That's on inspiration. Usually means a foreign body. A little kid that ate a piece of toy or something and it's stuck. Stridor, that's what it sounds like. And then stertor is labored breathing that produces a snoring sound. So when you're assessing somebody's chest, you're looking at their chest and their abdomen. Most of the time, especially with kids, it's easier to look at their abdomen because they're abdominal breathers. Men are abdominal breathers. Otherwise, you look at the chest. So you're looking for retractions. Retractions are drawing in on the muscle. It tells you that there's distress. Retractions can be intercostal, costal, in between the ribs, substernal, under the sternum, or suprasternal, above the sternum. The sternum is the breastbone. So anytime in any test question that you hear retractions, grunting, flaring, stridor, those are all key indicators that that patient is in an airway compromise. Hypoxia, not getting enough oxygen. Cyanosis, blue tinged. Cyan is a blueness of the skin. Cough, those are all signs that somebody's having respiratory distress. What do we do about that? Well, we usually put on a pulse ox right away. As nurses, we don't do ABGs, that's the respiratory therapist, unless, of course, you work in the ICU and you have some certain privileges to do that. That is not something we do, but we do need a doctor's order to get the respiratory therapist covered to do that for us. So we will talk about this. Arterial blood gases give you a pH, the oxygen and carbon dioxide measurements. Okay, arterial blood gases tell us where are we metabolically, respiratory. We can figure it out from those numbers. pH, acid or base, we'll be able to tell if it's too much pH or too little pH. It's causing the differences in the breathing. The pulse ox, so when you hear pulse ox, what are you reading? The O2 saturation, not stat, sat. So it's a little device you put on their finger and it measures the amount of hemoglobin going through the arteries at that time. It's non-invasive, so you can slap on a pulse ox on anybody. What should the reading be? Well, it depends on the patient. Double check yourself, okay? If the patient was COPD, we never want that more than 92, 93%. They are going to live in a constant state of 90. But anybody else probably will be just fine at 98%. 88, not so much. So non-invasive method of monitoring respiratory status. It tells us if we're in trouble. What else could be a problem about this external device? The nail polish, the smoker, the cold fingers. Okay. Recently, there was a study that pulse oxes are actually inconsistent with darker skin color. So we now know that O2 sats are probably better on lighter skin, so it may not be as accurate in darker skinned individuals. Just a word of caution. That is now just coming out, so we may have given oxygen to patients that really didn't need it. Hyperventilation. Hyperventilate. Hyperventilate. What does that sound like? Too many? Rapid, shallow breathing? Rapid, deep breathing? Hyperventilate. Hypocapnia. So it's excess loss. We're blowing off a lot of CO2. You start feeling lightheaded and tingly. Okay? This might also happen when you're anxious, when you're stressed, when you're in the middle of an anxiety attack. These are the things that you're going to hear in the case study that might get you to hyperventilation being the issue. When you have hyperventilation, the first system that comes to your rescue is your lungs, then your kidneys. So your lungs would come to the rescue. Hyperventilation is going to put you in a bad way. So what do we usually do to a patient that's hyperventilating? Give them a paper bag to breathe in? Exactly what we do. We want them to rebreathe some of that CO2. Hypoventilation is the rate and depth of respirations are decreased, so CO2 is being retained. They can't blow off all the CO2. Okay, so hypoventilation. Why would that occur? Think to yourself why somebody would not be breathing very much or very deep. This comes back to too many drugs on board, particularly your PCA, your pain pump. too many opioids, things like that. Okay, and then our blood pressure. So we're talking about blood pressure. This is one of the biggest ones you gotta figure out this quarter, this year, this semester. For the rest of your nursing career, you will be looking at blood pressures and what to do. If you want to go in the ICU, you're really looking at blood pressure because you're giving medications, minute medications, to make this happen for the patient. So it's an important indicator of overall cardiovascular health. It's the pressure of blood as it's forced against arterial walls during the cardiac contraction. So again, like I said, the systolic pressure, the diastolic pressure, the difference. Peak pressure exerted on walls as the ventricle contracts and ejects blood. When you fill up the bladder of the blood pressure cuff, the highest point that you get the meter to, you let go the meter, the little stopcock, and you're listening for that first gush of blood out of the arterial wall. Then the last one is the diastolic. That's the last minimum pressure against that wall. That's when the heart is at rest. So you're listening for that first and last beat that you hear. So blood pressure is measured in millimeters of mercury, and it's recorded as 120/80, and then typically in the computer system you just have to put 120 and 80 in there because this is already filled in. The pulse pressure is the difference between those two readings. So you may also hear the term main arterial pressure, okay? And that will come out on the blood pressure cuff reading that you get on a machine, but you would not have that readily available. If you're taking a manual blood pressure, you have to figure that out. So blood pressure is influenced by 3 factors: cardiac function, peripheral vascular resistance, and blood volume. Lots of factors influence blood pressure. The developmental stage. If I take you to the NICU, you will freak out seeing those numbers. Their numbers are so low. Literally, my adult people, when they go into pediatrics at Johns Hopkins, they freak out. They're like, oh my gosh, look at that blood pressure. Because you're so used to 120/80, 190/90. My babies are running 70/30, no problem. Gender, family history, lifestyle, exercise, body position, stress, pain, race, obesity, diurnal variations. Some people have higher blood pressure in the morning, some people have higher blood pressure at night. Medications that are causing differences in their blood pressure. Think about blood pressure is also stroke volume, right? So if you're dehydrated, there's going to be a difference. If you're overhydrated, there's going to be a difference. Medications that cause that. Diseases, especially vein wall disorders, arterial disorders, and then genetic variations as well. So there's indirect or non-invasive. That's the most common blood pressure you're going to do by using a machine or using a cuff. And then there's direct, which is invasive, and that's a catheter threaded up into the artery under sterile conditions, usually under surgical conditions, and it's attached to a tubing that's then connected to your electronic monitoring system, and a waveform is on the monitoring screen. This is something you will eventually learn in your last quarter, okay? Otherwise, we're doing an indirect method, which uses a cuff, a pulse pressure bulb, and a regulating valve, and a stethoscope. So, this is the machine. All you need is your stethoscope and you're ready to go. This is the machine. You don't even need your stethoscope because it's going to happen on its own. This is the problem. People don't know how to do this. They rely on this, and then we're in trouble when the doctor asks for a manual. That's why we still learn it, because it's an art and it is more accurate than your machine, especially if bioengineering hasn't done the resulting tests that need to be done on it. All right, so check for procedures in your textbook. Look for in the ATI, this checklist. Look in your clinical shell for the checklist for this. The basic steps and procedures is that you locate the artery. Where is the artery? We said brachial artery is up here. So you're coming down this side of your arm and then it crosses to the thumb. So you want to be on the pinky side of your arm, not the thumb side. So you want to make sure you find the artery. You put your stethoscope over that, then go ahead, put your cuff on, inflate the cuff with the bulb until the artery is occluded. In adults, that is typically known as 140. You ask the patient, how high is your blood pressure normally? If they say 160, then why are you going to 140, right? Typically, if somebody's not a blood pressure patient, we'll go up to 200 and come down, and then you know. But if you know that their readings are usually 90/50, why are we going to 200, right? All right, so deflate the cuff slowly. The blood begins to flow rapidly through the partially open vein, producing that turbulent flow that you hear the first time. That's the first number. Take note of what that number is. And then continuing to let the blood go, you're listening to the last sound. So in between, you will hear tapping, and then eventually you'll stop hearing any sound. Okay? Use those tools that I gave you. It will make it a lot easier. We will also pair people who have done this before manually with people who haven't. We will check that you understand what you're doing. Okay? All right. So, hypotension and hypertension. Both are medical diagnoses. Both are symptoms. They may be an etiology of a nursing diagnosis, and they need to be treated as a collaborative problem. All right, so let's look at this. A 44-year-old female comes to the clinic for a routine checkup. She provides you a card that has her last blood pressure readings, each taken a month apart. 118/78, 112/76, and 126/81. She asks you, what do these results mean? I only took them because my best friend has to monitor her blood pressure, so we do it together. How do you interpret her results? How would you explain these results, and what additional information is needed? So looking at those numbers, what are you thinking? Okay, I'm thinking this is normal, this is normal, this is normal. I do need, in order to have the doctor tell me that it's hyper or hypotension, I do need to know if she has any family history. I do need to know, is she taking any meds? Otherwise, I would tell her that she is normal. I would explain the results as anything over 140/80, 140/90 is concerning. Monitor your blood pressure. Your friend should monitor her blood pressure. She probably has different risk factors than you do. This is really good for you to routinely check your blood pressure, but at this point, it looks like you're doing great. Hypertension is a little different because there's different stages of hypertension. So originally, when somebody has a high blood pressure, we're not really going to worry about it. Most things in healthcare, you're not going to worry about with one thing, but if it becomes a trend on 2 or 3 occasions, then it's a problem, right? So when you see a history of people coming in once or twice a year, and their blood pressure is over 120 to 129 over 80, then you start being concerned a little bit. So you tell them, what's the first thing that they tell you, right? Most people here probably have high blood pressure and probably already know all about this. So what do they tell you the first thing? Cut out the salt, be careful with your diet, right? Monitor stress. Okay, once you get more than 2 or 3 readings of 130 to 139 over almost 90, then we call it hypertension stage 1. May or may not even add medication at this point, right? Might be preventative more than anything. These people have babies every day. That's chronic hypertension, right? Is it something to worry about? No, not when she's not pregnant. Okay. Hypertension stage 2 is anything 140 over 90 or greater. Okay. So that's when we worry and we really put them on meds and give them the whole spiel about diet and everything and call them hypertensive. Hypertension is a major illness in the U.S. and a cause of death in the U.S. It stresses the heart and the blood vessels. It can also really be even worse in people that smoke, right? So left untreated, it can lead to heart, renal, cerebral, and respiratory complications. That's important. A lot of people are like, oh, it's no big deal. It can cause changes to the heart. A heart under pressure is going to strengthen or weaken those walls. It's probably going to weaken the walls of the heart. Renal. What do we know about the renal system? The renal system gets rid of water. It can't do its job if it's under a lot of pressure. Cerebral blood flow. Cerebral under a lot of pressure. Do you think that's good either? Probably not. A stroke. Okay. Respiratory complications. The more I weigh, the higher my blood pressure, the potential for sudden death. Respiratory complications equals obstructive sleep apnea, respiratory complications as well. So it's not one thing. I have high blood pressure, that's it. A lot of these things increase in severity related to the increase in elevation of the blood pressure. So a lot of times test questions will say, the worst headache of my life. The worst headache of my life is definitely the patient to go back because their blood pressure is very, very high. If you see a blood pressure of 200 over 100, that's like, oh my gosh, I need to get him in the ER. We need to give him medications now. That's a problem. There's no reason to be under that much pressure. Your heart, your brains, your renal, whatever. Primary or essential hypertension. Diagnosed when there's no cause for the increase and accounts for 90% of cases of hypertension. A lot of times they don't even know that they have hypertension. What's the first reason why people, especially women, come into the hospital? To have a baby. So a lot of our patients end up being hypertensive or pregnancy-induced hypertension when they've been chronically as well. Okay. Okay. Hold on just a sec. Okay, so where I left off. The clinic nurse is reviewing the blood pressure readings from a patient's home self-monitoring device. The patient states, look, yesterday my blood pressure jumped to 150 over 90. I should be taking more medicine. The nurse's best response is, yes, that's dangerously high. What were you doing? Yes, I'm sure your provider will want to increase the dose. C. The provider will first look at the pattern of your results. D. Don't worry, I'm sure it's just because you were stressed. That's how you have to read them to yourself when you're doing these tests, because you want to look for the most therapeutic communication. That's dangerously high. What were you doing? You're hollering at them. Don't do that. The answer will never be why, right? On an NCLEX question, on an ATI question, it'll never be why. What were you doing? Don't blame the patient. Yes, I'm sure your provider will want to increase the dose just on one reading. What did I say? What did I just say in the recording? It's got to happen 2 or 3 times before we worry about it. We don't know. It might have been a one-time issue. Maybe she was stressed. Ask her, do you have any reason why it was up high? Was anything different going on? Right? Get a little more information. But what would you tell the patient? Probably not going to poo-poo on her, number D. Probably not going to tell her that the doctor should increase her med, because what if they don't? You're selling the doctor down the river. You don't really want to do that. What you want to say is, C, the provider will first look at the pattern of your results. If the provider feels that it's time to increase the dose, then he can. But it's typically going to be a 2 or 3 reading to get a trend. Okay. So trends, patterns, not a one-time thing. Okay? So remember, help with vital signs. Here's all your options to get help with vital signs. And then just a little, combination wrap-up summary. Vital signs are a combination of skills. Vital signs are temperature, pulse, respirations, blood pressure. Technically, we also put pain in there, right? But you will learn more about pain later in a different lesson. But remember, there's 5 vital signs. Technically 6 if you're diabetic, right? Because you usually, when you're going in for vital signs, you're doing the blood sugar too. If the nurse is telling you, hey, I need a blood sugar on them as a CNA, okay? So think about vital signs more comprehensively, not just a task, not just a number, but why are we getting these? It provides us an indication of the patient's state of health and functioning of body systems. That's why it's more than a task. Nurses can delegate the activity of taking vital signs, but the nurse is still responsible for the interpretation of vital signs, vital sign trends, and decisions based on abnormal vital signs. As a student nurse, you are responsible for the functioning of within your scope of knowledge. So we teach you how to change your mindset into a growth mindset from a fixed mindset. It's more than numbers. What are we looking at? That's what we teach you as a nurse, is how to be responsible for the interpretation of the vitals, the trends that you see, and the decisions to call the doctor, to give meds, to not give meds, things like that. So again, in summary, here are your helpful places you can go with these skills. We just wanted to make sure that you had vital signs stuff to get prepared for next week's lab when we get started on week 2 in the lab, because Monday we don't have any school. All right, thanks.